You're watching Structure in the Clinic, taking an intersectional, multidisciplinary and transcultural approach to teaching medicine as a social science. So in this video, I'm going to be speaking about knowledge production in medicine and how it's deeply bound up with power relations. And using these ideas about knowledge and power, begin to think about unpacking what it means to decolonize the medical curriculum. So these are the questions that I hope to start thinking through in this session. And I think it's useful to frame the aims of this session as questions. And this is because it speaks to the perpetual nature of these issues and the dynamic nature of these issues. But I hope that by the end of the session, we can deepen our understanding about three main ideas. First one, epistemic injustice. The second, the limits of biomedical reductionism. And thirdly, what decolonization might look like in the curriculum and in the clinic. So before we begin, I'd like to play a piece from the jazz group Sons of Kemet.
Considers herself our better. By right of blood,
So listening to that, how did you feel? Empowered, seen, perhaps angry? So there are three main reasons that I start with this piece of jazz. Firstly, it exposes and explicitly problematizes colonialism, both historically and how it persists in the present day. It forms an oral history of British nationalism and how it has its roots in empire, racism, and social inequality. It boldly states we claim the right to question your obsolete systems, and this is precisely what decolonizing medicine is all about. It's about questioning the systems that we use to think about, diagnose, and manage illness, especially those that we now know don't make sense and are not fair. Secondly, it is itself a piece of decolonizing work and resistance. It recenters and champions the voices of visionary black women who were systemically excluded by structurally racist histories and curriculums. And this again is part of what decolonizing medicine looks like, recentering the knowledge and lived experiences of people of colour, both healthcare workers and patients. And thirdly, the jazz itself is a rewriting and an expansion of the genre of jazz. It's experimental, it's improvisation. It's made with musicians from diverse ethnic and social backgrounds who may not necessarily be formally or classically trained. And it reflects their multicultural influences of the diverse heritages from where the musicians come. In a similar way, medicine needs to concern itself with expanding itself to be more inclusive and less rigid in the way that it is taught and in the way that it is practiced, so that it can reflect the diversity, both ethnically and socially, of the people who practice it and the people who it seeks to care for. So these pictures are taken from the Rhodes Must Fall decolonizing movement at Oxford University. And I want to draw attention to one of the striking messages that reads, "Don't diversify, decolonize." And this draws attention to a really central point. Diversifying into fundamentally unjust and unequal institutions does not and cannot eradicate the injustice and the inequality. We need to ask questions about power. Who has the power? That is, the money, the technology, the social capital, the political leverage to set the curriculum's agenda and indeed the research agenda. Who is left out of this agenda? Would including the people who are left out threaten the power of the institution as a whole? So when we're thinking about this, it can be easy to get lost in the source of abstract concepts and ideas. So I want to distill down to two key ideas and ground them in two concrete cases. The first point I want to make is that medical knowledge is not objective and value-free. Medical knowledge, like all knowledge, is constructed by social and political forces. The second concept is epistemic injustice. So, firstly, the social construction of medical knowledge. This paper discusses the process by which the 2009 NICE guidelines for the treatment of depression came about. I'm sure we've all referred to these guidelines many times, but have we thought about how NICE navigated conflicting and divergent opinions and viewpoints in the process of creating these guidelines? In essence, what this paper describes is how, when NICE was presented with well-known, robust evidence that highlighted significant methodological and conceptual limitations of the antidepressant trials that form the basis of these guidelines, it did not sufficiently engage with them or represent them in the process of creating these guidelines, and this is reflected in the final product. So the point that I'm trying to draw attention to here is that NICE has the power to choose which knowledge and whose knowledge, that is, which data, which philosophical slant, makes it into the guidelines that we use every day and consider to be objective. And it's important to ask, why is NICE privileging some evidence over other contesting evidence when both are equally robust? And here I don't want to give a prescriptive answer, but rather suggest some points to think around. So, in the 1 year following the publication of these guidelines, prescriptions for antidepressants in England rose by 48% to 43 million in just 1 year. One way of understanding what these figures show is a tending towards the medicalisation of human difficulty. So, who does this medicalisation stand to serve? Well, for one, it yields enormous power for the medical profession. Every time that we as doctors prescribe an antidepressant, we are being given the power to alter someone else's neurochemistry. So then we ask, whose neurochemistry are we altering? Who are we prescribing these antidepressants to? And often, it's the most vulnerable people in our society. It's often those who have been exposed to social problems and structural injustice like unemployment, housing insecurity, food insecurity. And we already know that Black and ethnic minority people are disproportionately employed in low-paid work and are more likely to live in deprived neighbourhoods. So when we see such a steep increase in antidepressant prescription, it's important to think about how we're taking this vast, complex, intrinsically social issue that differentially affects different social groups and locating it predominantly within an individual's brain, within their neurochemistry. What these guidelines do is they entrench within clinical practice the understanding of depression as a predominantly biomedical issue of chemical imbalance in the brain. So when NICE privileges the evidence supporting positive antidepressant trials and doesn't engage with the critique about the limitations of these trials, it's important to question, why are they producing guidelines that push forward this biomedical agenda, which in turn obscures the social dimensions of depression, inadvertently or otherwise? And by extension, how does this impede investment in and the development of alternative social and structural interventions that are needed in caring for people with depression? And at this point, it's interesting and important to note that the authors of these guidelines have declared financial conflicts of interests involving various drug companies that mass produce these antidepressants. So now, I want to make it clear, this is not to say that antidepressants don't have an important role to play in caring for people, because of course they do. Nor is it to say that NICE guidelines are not extremely useful in clinical practice, because of course they are. It's just about questioning and problematizing this inaccurate assumption that medical knowledge is objective. It's about acknowledging that knowledge production is not an objective, neutral process. It's constantly being muddied by the socially and politically informed ideas that we have as people before we became doctors and researchers and policymakers. So how does all of this relate to decolonization? Scientific objectivity is prone to being weaponized by empire. It's used to legitimize the colonial dynamics within medicine very often. For example, the term protest psychosis during the civil rights movement in America, where black men were pathologized and sedated under the guise of scientific objectivity. Western medical knowledge to this day continues to be championed as the most valid, the most credible, the most accurate, as a universal, unchangeable truth. And this is extremely dangerous because it dismisses alternative systems of knowledge and thinking that threaten the monopoly of Western thinking, and it dismisses them as primitive and negligible. And often this imperialism is masked as a social movement, and this is particularly concerning because it's masked as a movement that's there to educate, to develop and modernize, but it's primarily concerned with serving its own interests and protecting its own power. So this now takes us on to the second thinking point around knowledge and power, and this is the idea of epistemic injustice. Epistemic injustice is defined as a wrong done to someone, specifically in their capacity as a knower. So what does this mean? Ingrained, perhaps unconscious prejudice against certain social groups can mean that there is less credibility and validity attached to the knowledge that they have to contribute. So again, to ground this idea in a concrete example, we can look at the COVID-19 Public Health Review of disparities in risks and outcomes. And before I go on, I think it's important here to problematize a term that's used in this report, and that's the term BAME. It's important to explicitly state how harmful this term can be in the way that it homogenizes a very diverse group of people. And it's important to explicitly recognize how this term can erase the differences in experience of the people that it describes, in particular of the Black community. I use this term here because it's the term that is used in the Public Health England report. However, as I say, it's important to recognise that the BAME community is not a monolith, and there is differential rates of risk within the group, which we must strive not to obscure. So now, going back to the review. This review simply stated that Black and ethnic minority people are more likely to die from the virus than white people, with Black people having the greatest risk. This is not, or at least should not, be shocking, because it fits with the pattern of data that has existed long before COVID-19. For example, Black women in the UK are 5 times more likely to die in pregnancy than white women are, while Asian women are twice as more likely to die. Black patients are less likely to receive the analgesia that they need to relieve acute pain than white patients are. Asian patients with dementia were 14% less likely to be prescribed beneficial anti-dementia drugs than white patients were. This knowledge has always existed, and black and brown academics, healthcare professionals, activists, service users have been raising their voices about these issues for a long time. And yet what we see in the response to the ethnic disparity data around COVID-19 is the long-standing marginalisation and silencing of the knowledge that these voices have been seeking to contribute. We see this in how the mainstream media and even major medical journals have labelled the fact that black and ethnic minority groups are suffering the greatest insult during this pandemic as a mystery. But it's important to ask, a mystery to whom? We see this in Public Health England's deeply disappointing initial report that omitted any mention of structural racism as the primary cause of ethnic disparity in the COVID-19 death rate. We see this in how doctors and scientists instinctively choose time and time again to spotlight genetic and immunological factors as the culprit, ignoring the overwhelming evidence that the roots of the problem are predominantly social and political in nature. And this report needs to be called out for what it was. It was a whitewash. Health Service Journal reported that an earlier draft of the review had a section summarising over 1,000 black and ethnic minority community organisations and individuals who supplied evidence to the review, many of which suggested that structural racism was a significant contributing factor to the increased risk from COVID-19. So when Public Health England chose to omit these contributions in the final report, it was an act of virulent epistemic injustice. It dismissed the testimony of black and ethnic minority voices in its purposeful marginalisation of their narratives. Ignoring their contribution served to deflate their credibility. Such epistemic injustice is what translates into persistent social injustice. What this report allowed Public Health England to do was tokenistically acknowledge the ethnic disparity in the COVID-19 death rate, but overlook the need to generate a structural response. This clearly demonstrates how structurally unequal institutions like Public Health England will generate knowledge that erases and invisibilises structural inequalities so as to sustain themselves and their monopoly on power. So, using these things that we have talked about, here is a point of reflection. The practice of medicine in the clinic sees a collision of significant vulnerability with significant power. And as clinicians, we need to ask ourselves constantly and introspectively, how do we navigate this dynamic in a way that isn't harmful but is safe and helpful for our patients? So now we've fleshed out those ideas about knowledge and power, let's move on to thinking about biomedical reductionism. On the screen here is a quote from the play Arcadia, and I thought it would be an interesting point of entry into the discussion around biomedical reductionism. The unpredictable and the predetermined unfold together to make everything the way it is. And also, on a slightly tangential note, structural competency is about being committed to a multidisciplinary approach in medical education. And using this quote, I think, really speaks to how, from literature, there can emerge some really important ideas, really important knowledge that can be very, very helpful in informing and enriching the way that we learn and do medicine. So this play uses chaos mathematics as a metaphor for human behaviour. And at its very core is the question, how do we reconcile the ordered and the disordered, the predetermined and the unpredictable, our thinking and our feeling? And often these two things are presented as opposing, as conflicting, as a binary. But I think this quote captures something that's closer to the truth. And we can come back to this. But first, let's begin by defining what we mean by biomedical reductionism. So reductionism is the idea that if you take a complex phenomenon and break it down into its simplest parts, study and understand those parts, then when you put it all back together, you can have a good understanding of the whole. So in medicine, biomedical reductionism suggests that understanding illness begins and ends with pathophysiology. So if you can work back and isolate biochemical disturbances or physical lesions, then you can understand the disease as a whole. This perspective assumes very simple linear models of cause and effect that occur independent of a wider context. And what it does is it gives you something to target. Since this is the dominant framework of thinking in medicine, we're inclined to think that our role as doctors stops at discrete medical interventions. For infection, the target is a pathogen. For cancer, the target is the tumour. For depression, it's serotonin channels. However, when we're trained in this way of thinking, it obscures a key fact. Pathogenesis goes beyond the biological. Pathogenesis is necessarily shaped by the social, political, and economic conditions of the world around us, and it is shaped by this as much as it is by our biology. The way that medicine is taught and practiced needs to factor in this complexity rather than obscure it. A person's ethnicity, their occupation, their living conditions, their economic security, their political rights, their cultural background, their sexuality, their gender identity, their access to healthcare are all part of the etiology of disease. While here we have heavily focused on race, structural competency calls for intersectionality as indispensable to these conversations about how we learn about disease and how we practice medicine. Social values, culture, politics, these cannot be cursory considerations or tokenistic afterthoughts, but need to be the stuff of primary concern. And of course, this is not a call to do away with the biological dimension, but to incorporate the social dimension. And I think this is where we can go back to that initial quote from Arcadia. It's not as simple as a biological understanding versus the sociological understanding. It's far more interesting to think about what happens at the interface between these two things. How do our social worlds shape our biology? So again, to ground these ideas in a concrete example, I'd like to share with you a case that a friend shared with me. It was about a Rwandan woman seeking refugee protection who periodically presented to the emergency department with severe breathlessness, and every time she would be repeatedly diagnosed with acute exacerbations of asthma, and she'd be given oxygen, bronchodilators and oral steroids, and then discharged back home. Meanwhile, the damp in the walls of her social housing continue to render her vulnerable to further exacerbations each time she returns home. Compounding this, there's the understandable fear of contacting local authorities, who may be compelled to share her details with immigration authorities, which prevents her from resolving these living conditions that threaten her health constantly. So, conventionally practiced medicine that's predicated on this biomedical framework tells us that in asthma, the pathology lies solely in this woman's lungs, And of course it does. But by contrast, if we use a structural competency approach, this tells us that pathogenesis cannot be understood without considering the contribution of the substandard social housing and the hostile immigration policy to the complex multifactorial etiology of her disease. What's quite interesting from a medical ethics perspective is that often it is this principle of do no harm that is cited as the reason to follow scientifically objective evidence that's built on these reductionist research methodologies that try to control for confounders. Confounders being the economic, the social, the cultural factors that contribute to the etiology and the prognosis of disease. But an interesting question to ask ourselves is, who are we protecting from harm? And who are we perhaps exposing to harm by doing medicine in this particular way? And following on from that thought, how can we do medicine in a different way that does no harm to the greatest number? When we know that structural racism directly and significantly contributes to the ill health of our patients, we must engage with this socially and politically in our medical training and in our caregiving if we are to uphold the primary ethical responsibility as doctors to do no harm. The minimization of harm necessarily requires accounting for and engaging with this complexity rather than obscuring it or disregarding it as confounding. We cannot stop at saying poor health in ethnic minority communities is due to genetics or socioeconomic status. We have to go beyond this, and we have to explicitly say that it is due to structural racism. Once we have said this, we have to act. We have to politicize ourselves. We have to question the systems that govern the way that we are taught and the way that we practice, and hold them accountable for transformative change rather than tokenistic representation. If it is going to adequately care for its black and brown patients clinically, medicine must engage with them politically, and this is nothing short of the ethical imperative to do no harm. So as I come towards tying all these different strands of thinking together, I want to go back to this painting by Dora Lamb, which we used on our title slide. She's an artist based in London who paints musicians live as they perform at their gigs, and I've linked her Instagram below if you'd like to follow her. This particular painting, named Free the Storm, is of the jazz collective Steam Down, who perform improvised, unrehearsed jazz at their weekly sessions. And I think there's something to be said about how the artist has created this piece of art. There's a certain dynamism and an embracing of complexity in the way that the artist approaches the subject, that is, the musicians. The spontaneity of painting them live as they perform means that her work captures them in a particular historical moment that she herself is positioned within. And she paints the musicians in the way that she experiences their music, and this positionality is reflected in the art that she produces. So how do these reflections help us in thinking about decolonizing medical knowledge? Perhaps when we approach our subject, that is medical knowledge, we can begin to free it and expand it by thinking of it as dynamic and complex, like jazz, rather than static and objective. And alongside this, we can begin to think about our positionality. How are we positioning ourselves within the bigger picture? And as we go about producing knowledge, how is our particular positionality reflected in the knowledge that we produce? And through these reflections, we can begin to see ourselves more as interpreters of health and illness, rather than as steadfast knowers. And when we see ourselves as interpreters, We can come at medicine with a structural humility that makes space for alternative, perhaps very divergent interpretations from our own. Being comfortable with that sort of pluralism of knowledge goes hand in hand with being comfortable with relinquishing some of our power. As I come to a finish, I'm just going to read these poems to you and leave you to contemplate them. And I highly recommend getting a copy of Manzoor Khan's brilliant collection of poetry, Post-Colonial Banter, which is again going to be linked below. From Where Is My History? Whilst those of us who are still seen as backwards, who don't get the time or space to explore artifacts, are in fact the outcome of their unnarrated relations to colonial plunder and false salvation. So when you ask where my past is, ask instead what yours is without mine. From Decentering Diversity. Equal access to unjust systems is not liberation. More people of colour on pedagogically unchanged reading lists is not salvation. And no number of black and brown faces in universities can fundamentally undo the racism. Just because they give you a seat at the table doesn't mean they're prepared to change the room. And on a final note, this is a political moment with great potential for change. The anti-racism and decolonizing movement is quickly gaining traction in areas where it's been needed all along. There's an urgency, and that urgency is necessary because these issues are urgent and these questions are urgent. But at this time, it is important that we are mindful of tokenism. These must be the beginnings of continuous conversations because these are perpetual questions, ever-changing and dynamic. Learning and unlearning, constructing and deconstructing, it will be as painstaking as undoing knitting. But this being said, as Arundhati Roy recently wrote, the pandemic is a portal. It has given us the space and the momentum to reimagine a counterfactual, an alternative way of doing things. And this is fertile ground for collaboratively working together towards a transformative and inclusive agenda.